Hello, welcome. My name is Dr. Moshe Appel. I'm a clinical psychologist and I have a group practice called ADO Psychology Center where we specialize in ADO, anxiety, depression, and OCD. And I also post videos on my website on these topics, which is adopsychology.com. So the topic for tonight's talk is taboo OCD. Taboo OCD? Yes, there are a certain group of subtypes of OCD that are labeled under this category, and we're going to figure out why and what those symptoms look like. But before we jump into that, let's briefly discuss what OCD is not, and then what OCD is, and then what is the specific subtype of OCD, and what can we do about it. So what OCD is not is when people say things like, I'm so OCD about everything, or they're so OCD about everything, or, people that enjoy doing things in a certain way, or maybe they're a little bit of a perfectionist. That is not necessarily OCD. OCD is a clinical disorder that's characterized by very distressing, intrusive thoughts, urges, or images, such as thoughts like, am I being contaminated? Am I, if I'm driving a car, did I not realize that I caused an accident to happen without realizing it? Or, other types of intrusive images, maybe inappropriate images that the person doesn't want to have in their mind. So that's what OCD is. It's this disorder of intrusive thoughts, urges, or images that compels the person to engage in compulsions, to do things to reduce that distress. So in the typical example of contamination, they might wash their hands a lot to reduce that distress. So a few other examples of typical OCD that most people are aware of are things like contamination, or needing to do things evenly or in a certain number, or maybe mental counting, or maybe checking the stove multiple times or checking the door multiple times. And within these categories, in real OCD, there's a tremendous suffering. The person is not happy with their symptoms. They're not happy that they have to do the things that they have to do. They just feel compelled to do them. They wish the symptoms will end. And many times, unfortunately, there's a lot of suicidality or suicidal thoughts. In fact, there are about 44% of people with OCD have thoughts about suicide. So let's jump now to the taboo OCD subtypes. And we're going to categorize them by aggressive OCD, harm OCD, sexual taboos, religious OCD, and relationship OCD. When it comes to aggressive subtypes, these are subtypes where the person has intrusive thoughts about acting in an aggressive way, not because they want to, not because they actually are aggressive type people, but usually for the opposite reason. They are so concerned about the possibility of acting in an aggressive way that they just can't tolerate that uncertainty. So for example, someone might have the thought as they're cutting vegetables in the kitchen, what if I just took this knife now and stabbed someone with it? And then they think to themselves, that's a terrible thought to have, and who has these thoughts? And then it becomes a bigger deal, and now they come to the point where they're so afraid of using knives to cut vegetables because of this what if that they're having in their brain. Other examples might be, what if I, push someone in front of the subway, right, as a train's coming in, or push someone into traffic. These are types of thoughts. Or what if I just slammed on my gas pedal and cause an accident? These are all different types of aggressive type thoughts that an OCD sufferer is not actually going to be engaging in, but they're so afraid of it. OCD in general targets places where we put our values in. So for religious people, it might be religious OCD, but most people care about not hurting people and things of that nature. So usually people with OCD, many times, they are actually least likely to act in these aggressive ways, but they still have these intrusive thoughts. Other examples like harm OCD is where I might accidentally harm someone. So I might accidentally have hit someone with my car without realizing, and therefore I need to drive back around the block a few times to check whether that happened. Or maybe I will accidentally, without realizing, walk too fast and push someone into traffic by accident. There's also harm OCD about the self. What if by mistake I might, harm myself in some kind of way? A very common, unfortunate, it's not super common, but it's definitely common enough within this community, is called suicidality OCD, which is not where someone's actually at risk of suicide, but they have this thought of what if I committed suicide. So I actually once had a patient who was pretty doing well in school, but the OCD was under control. But when it came to OCD about suicidality, she couldn't handle that anymore because that meant if I did that, that'd be really bad. So she had to take a leave of absence from school and go home, all because of this irrational, intrusive thought related to suicidality. So it's very important to do a differential diagnosis, and soon we'll talk about how, but if someone actually has suicidal thoughts or engages in such behavior, it should be taken seriously, obviously. However, if someone is just overly concerned over the possibility, but it's not reality, it's just OCD, that could be a very distressing form of OCD. And many times people check themselves into hospitals for that form of OCD, even though it's not actually a risk of suicide. Other example, the issue with the suicidal OCD is many times, as I mentioned before, people with OCD have suicidal thoughts, or they're also depressed, and so sometimes there is some truth to that thought, but then it gets overblown by the OCD. And that becomes a little bit of a complicated presentation that a skilled clinician should be able to handle. Other examples of taboo OCD, including sexual taboos, so intrusive thoughts of maybe I'm a pedophile, or when I pass by a kid's playground, what if I acted inappropriately there? And again, these people never have a history of such behavior. They don't actually enjoy those thoughts. They hate those thoughts, but they're so afraid of the what if and the maybe. And I can't stress this point enough, that these people we're not talking about people that have actual desires, or are actually at risk of being a pedophile in this case, but rather it's just the what if and the maybe that they can't shake. Other examples might be, inappropriate sexual thoughts or intrusive images, or thoughts about engaging in sexual activity with people that you shouldn't be. Anything along those lines could all fall into this type of OCD, and it's very distressing. It's not enjoyable thoughts for the person, but rather it's distressing, and they hate it, and they wish it could stop. Other examples of taboo subtypes are religious OCD, relationship OCD, but I made separate videos on these topics, so you can check those out if you're interested. So the question is, are these subtypes really rare, or they're just not discussed? And the answer is, they're really just not discussed. But there was a study done by Anthony Pinto at Zucker Hillside Hospital, who's a researcher in this area of OCD, and he looked at a sample of OCD participants and asked them, what type of intrusive thoughts are you having? And close to 50% identified aggressive OCD thoughts. So it's definitely not uncommon within the OCD population. However, it's not spoken about much, and as a result, many people are not aware of these subtypes, which unfortunately contributes to the stigma around the issue and also to barriers to reaching out and getting the help that the person needs. In another study, they found that 80% of physicians, doctors who are the first line of treatment, were not able to recognize these types of OCD. And even more concerning, 50% of therapists, part of the APA, American Psychiatric Association, were not able to identify various taboo OCD subtypes. So unfortunately, it's not rare, it's just not spoken about and therefore not as well known. So it's important to differentiate between true issues like true suicidal thoughts or true pedophilic tendencies versus just OCD. And so how do we do that? Well, I'll just tell you a few things to keep in mind to try to make that differentiation. One thing is past behavior. Past behavior is the best predictor of future behavior. And so if the person has engaged in some form of suicidal behaviors or some form of inappropriate sexual behaviors, then it's something to take into account. Now, just because someone has it does not necessarily mean that they don't have this form of OCD. It could very well be that they had this one-off, inappropriate behavior in the past. Maybe when they were a kid, they were exploring, experimenting, whatever it might be. And now that's haunting them for life, and they developed OCD around that. So that's definitely possible. But one thing you want to keep in mind when you're trying to differentiate is past behavior. You also want to think about whether it's ego syntonic versus ego dystonic, which is just a fancy way of saying, are these thoughts and behaviors in line? Are they enjoyable to the person? Are they in line with their values? Do they identify with them? Or are they distressing? Are they outside the purview of this person's values? Are they not enjoyable and they wish they could stop? So if it's ego syntonic, if the person's enjoying it and it's causing them actual pleasure, that points to not being OCD. But if it's very distressing and they wish these thoughts would go away and they don't enjoy when the thoughts happen, then it's more likely to be OCD. But this can be very complicated because many times we're humans, and so there may be a combination of some parts of the thoughts that are enjoyable, some parts that are distressing, or in the suicidality case I said before, some of their thoughts may be actual suicidal ideation, like thoughts about suicide. Some of them might just be OCD blowing it out of proportion, and that's why it's very important to work with a skilled professional in this area in order to differentiate between what is OCD, the parts that are OCD, and what are the actual issues that might be at play. So what does treatment look like? Well, treatment starts with proper diagnosis. And there are cases where people are diagnosed with certain types of OCD, There could be a case of relationship OCD. That's not relationship OCD. It's just relationship issues or anxieties about the relationship. It could be someone's diagnosed with pedophilia OCD, but actually the person actually is at risk of being a pedophile or enjoying those kind of thoughts or behaviors. And so proper diagnosis is obviously very important. Next step, assuming the person actually has the taboo OCD subtype, is to engage in psychoeducation and normalizing. So really providing, like the statistics I mentioned before, that many people with OCD, about half, experience some form of taboo OCD thoughts. And also recognizing that many people in the world, even without OCD, experience sometimes intrusive thoughts, like what if I just pushed someone in the subway, or what if I just slammed on the gas pedal? And it doesn't necessarily reflect true of the character, of your character, of who you are. But you don't want to engage in reassurance. So in OCD, we want to provide good, solid psychoeducation in the beginning, but you don't want to constantly be reassuring the person and tell them, no, you don't have to worry about it, you don't have to worry about it, because that's never going to be enough for them. And instead, they have to learn how to tolerate the uncertainty of it. And then ERP, acceptance of healthy aggression, is another very important piece of it, because healthy aggression is this idea that you can't hold yourself to too high of a standard. So for you to say, like, if I had a thought of wanting to punch my neighbor in the face is a big problem that I had that thought, that's not how humans are built. Humans are built to sometimes have extreme thoughts, and that's okay. The problem becomes when you make a big deal about that thought. If you just shrug it off and say, okay, that was a weird thought, and you move on, usually that tends to prevent issues from occurring. And then ERP, exposure and response prevention, is considered the gold standard treatment for OCD in general, and it applies to these taboo OCD subtypes as well. So for example, you might have someone minimize their compulsions, slowly face their fears, learn how to tolerate uncertainty, and engage in exposures, as I mentioned in some of my other videos for religious OCD and relationship OCD. And I also post these videos on my website where I go into more detail. So if you're interested in learning more detail about taboo OCD or the other OCD subtypes or treatment, definitely check that out at ADOpsychology.com. So in summary, what we spoke about today was the taboo OCD themes, and that they're neither more dangerous nor more rare than other OCD subtypes. It's just another one of those OCD subtypes. We've also spoken about how it's important to work with a skilled professional who can differentiate between these taboo OCD subtypes versus actual issues. And we also discussed briefly what treatment might look like. Thank you all for joining. If you want to send me any questions, you can put some in the chat right now, or you can contact me through my website, ADOpsychology.com. Thank you all for joining. Have a great night.